Busy week with Thanksgiving coming up, so I appreciate it. I'm excited to present a patient case, one of our patients with pancytopenia associated bleeding, and then we'll walk through kind of evaluation and management of bleeding in similar patients. Um, I'm definitely not going to fill the full hour, so there will be time for questions at the end, but also feel free to interrupt me as we go along. There we go. So I have no disclosures today. Learning objectives will, after the case, review the mechanisms of bleeding and pancytopenia, identify clinical features beyond thrombocytopenia that are impacting hemostasis potentially. We'll do some brief interpretation of diagnostic tests of hemostasis, and then also discuss the role of hemostatic agents in controlling bleeding secondary to thrombocytopenia. So starting with the case, we have a 15-year-old female with history of Hashimoto's thyroiditis. She presented with 2 weeks of prolonged epistaxis with episodes lasting up to 2 hours. She also endorsed migratory arthralgias. She had a conjunctival hemorrhage, labial ulcers, which were treated with diflucan a couple weeks prior to presentation at an urgent care. She also reported vaginal pain, some kind of acute on chronic diarrhea. She was experiencing dysuria, was also feeling pretty lightheaded and unsteady. She had a decreased appetite, along with unintentional weight loss of about 30 pounds over the last couple of months. 3 days prior to presentation, she began having fevers. And then what kind of brought her back into the ER prior to admission was a syncopal episode at home. Her family history was pertinent for a maternal cousin with Crohn's disease. Hashimoto's thyroiditis was also pretty prevalent in the family, in her maternal aunt, maternal grandmother, and mother. And then she also has a maternal cousin with psoriasis. So she initially presented to an outside hospital, and she was admitted there for about 8 days before transferring to Mott. This was the initial physical exam I found from the outside hospital at time of presentation. And it was pertinent for fever to 38.7 degrees Celsius. She was a little bit tachycardic with the fever. Otherwise, vital signs were unremarkable. On exam, she was overall pretty well appearing, although did have some dry mucous membranes. They noted a thick kind of yellow-white coating on her tongue. She did have also a left conjunctival hemorrhage. There was an area of kind of like a linear area of petechiae on her right upper chest. And then they also noted an erythematous kind of macular papular rash on her lower face, neck, and upper chest. She also had some healing wounds on her right wrist and then multiple kind of scabs on her bilateral lower extremities, which they thought were consistent with bug bites, and then also some kind of healing scars there too, which they thought might have been old bug bites that she had. Otherwise, her exam was pretty unremarkable. Um, Throughout that admission at the outside hospital, they didn't document a GU exam, so it's unclear at presentation if she still had labial ulcers. Although by the time she was transferred to our care center, she reported that they were resolved. So for her initial workup, labs obtained in the emergency room revealed pancytopenia. Her white blood cell count was 1.8. Her red blood cell count was 1.93. Hemoglobin was low at 6.5. Hematocrit low at 17.5 with a pretty low reticulocyte count of 0.63% and an absolute retic count of 17.1. Platelet count low at 12,000, and her absolute neutrophil count was low at 840. There weren't any signs on initial labs of any active hemolysis. She had a normal haptoglobin, normal bilirubin. However, her DAT did result, I think, the following day and was positive, 2+ for IgG and C3 negative. Also resulting later, her anti-neutrophil antibodies and anti-platelet antibodies also came back positive. She was also notably lymphopenic at presentation with an absolute lymphocyte count of 600. Her CD4, CD8, and CD19 counts were also low. IgA was slightly low at 49, and her IgM and IgG levels were normal. She did have kind of a nutritional workup sent initially to evaluate pancytopenia, which was largely unremarkable. She had an infectious workup, which was pertinent for a positive urine culture, which grew E. coli. Blood cultures were negative. Her HSV1 and HSV2, she was IgG positive, and then otherwise was negative for CMV, HIV, EBV, hepatitis panel, and TB quant were all negative. Some rheumatology labs were sent, and her ANA was positive. And then from there, she had a positive double-stranded DNA. Her thyroid peroxidase was elevated at 93. She also notably had a positive lupus anticoagulant screen with a prolonged DRVVT at 52.7. Her DRVVT ratio was elevated, and then her hexagonal phospholipid neutralization was also elevated at 14.7. Interestingly, her PTT was actually normal at 31, despite the positive lupus anticoagulant testing. We'll talk about that a little bit later in the presentation as to why that may have been. And then her PT was also normal at 11.6. We did send peripheral blood for leukemia and lymphoma flow cytometry, which came back unremarkable. She also underwent a bone marrow biopsy, which was pertinent for markedly hypocellular marrow at less than 5%, with decreased trilineage hematopoiesis and no evidence of neoplasm or dysplasia. And then just recently, her NGS myeloid panel also resulted with 2 TP53 variants as well. In regards to kind of bone marrow failure workup, her fecal elastase was notably low at 5.8, although her pancreatic isoamylase was normal, which was reassuring. And then her telomere length and chromosomal breakage were also normal. She does have whole genome sequencing that was sent and is still pending. And we did ask our genetic colleagues to see if they can also particularly hone in on the SBDS gene, just given the fecal elastase results. So she was ultimately diagnosed with lupus and has been following with our rheumatology colleagues. Her pancytopenia at this point, we're attributing to either aplastic anemia secondary to SLE, which is rare, or potentially an idiopathic aplastic anemia versus a bone marrow failure, such as Shwachman-Diamond with the low fecal elastase, and are hoping to narrow things down once we get her whole genome sequencing back. She was started on lupus-directed therapy, including high-dose steroids, rituximab, and hydroxychloroquine. And her counts have had a nice improvement. Her neutropenia had resolved with lupus-directed therapy. Anemia was improving, and she's been transfusion dependent for probably about a month now. However, her platelet counts continue to be low in the low teens, and she's been continuing to receive 3 times weekly platelet transfusions at this point. And also of note, she's continuing to experience recurrent epistaxis, presumably secondary to her ongoing thrombocytopenia, although it is slightly improved compared to, and less severe at least, and less frequent compared to when she initially presented in October. So similar to our patient, I think we're all pretty familiar that for individuals with thrombocytopenia, common bleeding manifestations are mucocutaneous. In particular, we see a lot of petechiae and purpura, lots of easy bruising, recurrent nosebleeds, oral mucosal bleeding. Heavy menstrual bleeding is pretty common, as well as postpartum hemorrhage. Less commonly, we can also see hematuria and gastrointestinal bleeding. Surgical and trauma-induced bleeding is also common, especially for surgeries if we're not aware ahead of time that they're happening and aren't prepared for them. And then incidence of intracranial hemorrhage secondary to thrombocytopenia kind of varies based on the underlying etiology, but thankfully is generally pretty rare. And then I'll also just point out that with thrombocytopenia, we don't tend to see kind of the spontaneous like hemarthrosis and intramuscular bleeding that we can see with some of the other congenital bleeding disorders. So mechanisms of bleeding in the setting of pancytopenia can be multifactorial. I think the obvious explanation for bleeding is thrombocytopenia, as platelets play such a pivotal role in primary hemostasis. The goal of primary hemostasis is, as we all know, is formation of the platelet plug, which provides kind of temporary hemostasis. Kind of following endothelial injury, there's exposure of circulating blood to elements in the subendothelium, primarily your von Willebrand factor and collagen. Platelet adhesion occurs as your circulating platelets bind to the collagen and von Willebrand factor. And then once platelets are adherent to the subendothelium, they undergo activation and conformational change, which increases their surface area to allow for increased adhesion and also trigger secretion of platelet granules, which contain various proteins and cofactors that aid in platelet recruitment, adhesion, activation, and aggregation. The platelet surface membrane also becomes negatively charged in this process, which provides a procoagulant surface for assembly of your coagulation factors and ultimately generation of thrombin. In addition to thrombocytopenia, it's been proposed that in pancytopenic individuals, anemia is also associated with bleeding risk. The theory is that red blood cells concentrate in the center of blood vessels as they flow through vasculature, forcing your platelets to the periphery where they can interact with von Willebrand factor and collagen along the endothelial surface. In non-anemic states, hemostasis is maintained fairly well, even in the setting of thrombocytopenia. However, with reduced red blood cell mass, as in addition to thrombocytopenia, platelets tend to stay centrally and they have decreased contact with damaged endothelium, leading to impaired hemostasis in the setting of thrombocytopenia. There is some clinical evidence to support this theory that anemia is a modifiable risk factor for bleeding in individuals with thrombocytopenia. The Plato trial, which investigated the dose of prophylactic platelet transfusions, if that had an impact on bleeding outcomes, found that hematocrits less than 25% were associated with an increased risk of bleeding in the setting of thrombocytopenia. There have also been several randomized control trials conducted in individuals with pancytopenia due to hematologic malignancies, which compared bleeding in individuals with a liberal versus restrictive RBC transfusion goal. The goal for kind of the restrictive transfusions varied from a hemoglobin of 7 to 8 in the different studies, and the liberal hemoglobin goal varied from 8 to 12 in these studies. No definitive conclusions could be drawn. There were kind of a lot of different results seen in those studies. Though more severe bleeding was observed in the restrictive transfusion arm in one of the studies. However, it wasn't a statistically significant finding. Similarly, there was a prospective study done to evaluate the impact of RBC transfusions on bleeding time. And this study found that when kind of pre-transfusion hemoglobin was less than or equal to 6, the bleeding time was notably shorter following a transfusion. Anecdotally, kind of thinking back to our patient who is still experiencing epistaxis, it has overall improved since presentation, despite continuing to have kind of similar platelet naters, kind of in the low teens, as which is where her platelet count was when she first presented. Her hematocrit, however, was around 17 at time of presentation, and since initiation of immunosuppressive therapy, the majority of the time it's been, above 25. Without PRBC transfusions, and we have seen an improvement in her epistaxis without too much other intervention. So, well, besides the frequent platelet transfusions, but potentially the higher hematocrit is also helping a little bit with her bleed control. So, one important question I think to always ask is if the degree of bleeding is appropriate for the degree of thrombocytopenia. And I think we have to keep in mind that clinically significant bleeding is rare with platelet counts above 30,000. And additionally, kind of major bleeding is pretty rare with platelet counts above 10,000. Again, thinking about our patient, her platelet count has kind of ranged from 13 to 25,000 since presentation. And apart from the epistaxis, she's not really experiencing other bleeding symptoms. So I don't think her bleeding pattern is necessarily all that atypical. That being said, even though this patient I presented kind of is following the hemostasis textbook, I'm sure we can all think of kids that we follow who just have a ton of bleeding despite relatively, higher platelet counts. And so when bleeding seems to be excessive, I think it's always best to go back and take a more thorough bleeding history to determine if, there is a concern for an underlying congenital bleeding disorder that may have been unmasked by the pancytopenia. Digging deeper into, history of bleeding prior to pancytopenia, including any prior surgical bleeding they've experienced, bleeding with eruption and exfoliation of primary teeth, taking a more detailed menstrual history can be pretty important. For individuals who are menstruating, any history of bleeding for more than 7 days, changing, sanitary products every 2 hours or more frequently, having more than one period in a 21-day cycle should kind of raise a red flag that further workup is needed. Also, exploring family history can be helpful, paying particular attention to a lot of the same things. Any family members with heavy periods, postpartum hemorrhage, surgical bleeding, any history of premature joint disease that might make you think of like a hemophilia, can all kind of lead you down a path to certain workups. Reviewing medications is also important and useful. There's dozens of medications that can impact our platelet function, but I think three common groups that are pretty well documented are NSAIDs, SSRIs, and anti-epileptics. And while I think it's pretty standard for all of us to counsel our patients who have low platelet counts to stay away from NSAIDs, that's not typically standard for kids who are on SSRIs and anti-epileptics. And I think if we ruled out everything else and it comes down to us thinking, maybe their extra bleeding is from an SSRI or anti-epileptic use, we need to be pretty thoughtful. And I think the focus should be on really trying to prevent and control the bleeding rather than jumping right to medication changes, just because sometimes switching up these medications can cause more harm than good. Other things to always think about too are hypermobility syndromes, such as Ehlers-Danlos syndrome, that can be associated with various bleeding symptoms due to collagen defects. Screening for hypermobility syndromes is pretty simple. You can do a quick Baton in the office to see if you have concerns for hypermobility. And while there's not necessarily a standard of care for treating bleeding and connective tissue disorders, sometimes vitamin C supplementation can be beneficial, especially for kids who are having recurrent mucocutaneous bleeding. And then lastly, it's also important to think about acquired bleeding disorders. Acquired von Willebrand syndrome in particular is associated with a variety of underlying disorders, including lymphoproliferative disorders, cardiovascular, myeloproliferative, neoplastic, and then other autoimmune disorders, including lupus, like our patient has. There are also some acquired bleeding disorders that are fairly common in addition to acquired von Willebrand syndrome, including, DIC, which we're all familiar with, liver disease, and vitamin K deficiency. And there are also rare acquired disorders that exist that we don't always think about, but shouldn't be overlooked, especially if you're a little bit stumped, including acquired factor V inhibitors after bovine thrombin exposure, acquired hemophilia, and then also lupus anticoagulant hypoprothrombinemia syndrome. So after obtaining kind of additional history, if you are suspicious of a disorder of primary hemostasis based on, maybe a family history of lots of individuals with mucosal bleeding, then testing for von Willebrand disease will certainly be important. For most of our patients with thrombocytopenia, typically their platelet count is too low to allow for kind of full platelet aggregation and secretion testing to evaluate for functional defects. You can always consider, flow cytometry testing for some of the more severe platelet disorders like Bernard-Soulier or Glanzmann's thrombocythemia. However, in general, those do tend to be more severe bleeding disorders that typically are noted in early childhood. And so I personally don't always screen for them unless bleeding seems really severe. If there is a concern for, disorders of secondary hemostasis, if you're getting the sense that there's some X-linked pattern of inheritance going on in the family, or there's a lot of men in the family with early joint disease to make you think of hemophilia, then certainly testing for, those specific factor deficiencies can be beneficial. And then if you're kind of stumped, disorders of fibrinogen should always be thought about since they can impact both primary and secondary hemostasis. In 2021, the American Society of Hematology, along with ISTH and the National Hemophilia Foundation and World Federation of Hemophilia came together and released these wonderful guidelines to help with the diagnosis of von Willebrand disease. I know I personally reference them probably multiple times a day and have been really helpful. But if you haven't looked at them, they're great. They have, I think there's 11 recommendations that they release for diagnosis. One of the great things they did was they kind of created clear guidelines for von Willebrand factor level cutoffs for diagnosis. And they proposed that a diagnosis of von Willebrand disease should be given to any individual with von Willebrand factor levels that are less than 30% regardless of bleeding. And then for individuals with kind of levels between 30 to 50%, if they're also exhibiting abnormal bleeding, then they also should be given a diagnosis. They also pointed out that if within your lab, the lower limit of normal range for your von Willebrand factor assays is less than 50%, then you don't need to use any ABO-specific reference ranges. And then likewise, they also provided new guidelines that updated kind of classifying the subtypes of von Willebrand disease. And so to distinguish type 1 von Willebrand disease from type 2, we're now using a ratio between your von Willebrand factor activity and antigen of greater than 0.7 for diagnosis of type 1. And then if that ratio is less than 0.7, then it's more consistent with a type 2 von Willebrand disease. And then from there, kind of multimer analysis can be helpful to kind of tease out the type 2 VWDs from each other. Type 2N is usually going to be identified because there's also a low factor VIII activity due to impaired binding. And with type 2B, oftentimes we'll also see thrombocytopenia, although the new guidelines are recommending genetic testing to kind of help distinguish between type 2A and type 2B now. When interpreting von Willebrand factor levels, I think it's extremely important to keep in mind that there are many, many, many factors that might be influencing the levels based on what was going on at the time you drew the panel, including age. So for infants, it's difficult to rule out von Willebrand disease in kids less than 6 months of age. And that's really because your von Willebrand factor levels are typically elevated at birth due to stress. Turns out being born is a pretty stressful event for kids, and their levels tend to stay kind of elevated above their baseline for the first 6 months of life. And so oftentimes, if there's not a pressing need to test during that time, it's often advisable to wait until kids are a little bit older. However, if you have a baby with pancytopenia who's having, lots of atypical bleeding, then I don't think it's, wrong to test during that time period. Just know that you're likely going to have to retest when they're a little bit older to see if there's been any change in the levels. Several studies have also been done kind of trying to tease out when is the best time to test women who are menstruating. And studies have shown that in individuals without von Willebrand disease, their VWF levels tend to be lowest during the first 4 days of the menstrual cycle. However, more recent studies in individuals who are experiencing heavy menstrual bleeding, it's been shown that VWF levels are typically elevated during that acute period of heavy bleeding. Likewise, studies have shown that for women with severe iron deficiency, usually there's an associated increase in their von Willebrand levels. And so for a lot of our patients who are experiencing bleeding and are iron deficient, that can also be playing or impacting levels, and we need to consider that when interpreting testing. In general, though, it's now recommended to not test during kind of heavy periods of heavy bleeding. And it's also not advised typically to do diagnostic testing for von Willebrand disease during pregnancy, as elevated estrogen levels during pregnancy can also lead to increased von Willebrand factor levels. After birth, your von Willebrand factor levels typically return to normal after about 4 weeks. However, that can be, it can sometimes take longer, particularly in women who are breastfeeding. Other things that can kind of falsely increase von Willebrand factor levels above baseline include hormonal therapies, cigarette smoking, a history of atherosclerosis and liver disease. Von Willebrand factor levels can really be increased during any kind of stressful event, including, acute illness or infection. If there is someone who's really stressed for, having their blood drawn, that alone can increase your levels. Chronic inflammatory conditions also can make it really difficult and challenging to diagnose von Willebrand disease because that can also increase levels above baseline, especially during acute flares. And so, if possible, it's always advised to not do diagnostic testing during acute disease flares. But again, if you have a patient who is newly diagnosed with something like lupus and are inflamed, reasonable to test if they're having a lot of bleeding, but just know that it might be needed to retest them at a later time as well to reinterpret things. And then things like, chronic inflammatory conditions, stressful events can increase your von Willebrand factor level 6 to 8-fold. And so if you are testing someone during kind of an acute disease flare and their levels are kind of borderline, maybe their von Willebrand factor levels are in like the 50s, 60s, that in my mind, definitely I would be suspicious that they might have underlying von Willebrand disease that's just being kind of masked by that underlying inflammatory process. And then there are also conditions that can kind of falsely decrease your von Willebrand levels, including many autoimmune, myeloproliferative, and cardiac disorders. Kind of switching gears a little bit, if you are kind of suspicious for an inherited factor deficiency, It's also important to consider whether or not the PT and PTT are reliable or if you need to do kind of more specific factor testing. And in general, I tend to recommend doing specific factor assays. Depending on the sensitivity of the PT and PTT assays in your lab, you can actually miss mild factor deficiencies. Can have a normal, I know in our lab at least, we can have normal PTTs in patients with mild hemophilia pretty frequently. Likewise, there are various lab errors that can occur. If you're underfilling tubes, that can alter the ratio of plasma to the citrate that's in that tube, trying to prevent it from clotting. When you underfill the tubes, there is kind of a relatively higher citrate concentration compared to plasma that can lead to falsely prolonged PTs and PTTs. Likewise, for patients with really high hematocrit, so kids with congenital heart disease or patients with myeloproliferative disorders, again, you're kind of creating the same effect as an underfilled tube. So when you have a really high hematocrit, you have relatively less plasma being collected in that tube. And so again, relatively, the citrate concentration is going to be higher than it needs to be. And you can have falsely prolonged PT and PT assays again. And then lastly, for patients who may have underlying inflammatory disorders or are maybe acutely ill and are inflamed from that, a lot of clotting factor deficiencies can be masked in the PT and PTT. So during inflammation, oftentimes your factor 8 and fibrinogen levels are going to be increased because they are acute phase reactants. And so if you have, a PTT with a really elevated, or I'm sorry, if you have a patient with a really elevated factor 8 level, their PTT can be falsely shortened and could, or maybe just normal, but could mask like a factor 9 or factor 11 deficiency. Likewise, if you have a patient with a fibrinogen that's elevated, both the PT and PTT can be falsely normal in the presence of factor deficiency, any factors in kind of the intrinsic, extrinsic, or common pathway. And then elevated factor 8 and elevated fibrinogen can also mask lupus anticoagulant as well, if you're only relying on a PTT assay to try and detect the lupus anticoagulant. So thinking back once again to our patient who clearly had a lupus anticoagulant with the prolonged DRVVT and elevated hexagonal phospholipid neutralization, but had that normal PTT. I think that's likely what was going on. We didn't actually measure a factor 8 level for her, but my guess is that in the setting of kind of a new lupus diagnosis, along with the positive E. coli in her urine, likely her factor 8 was probably pretty elevated and was likely kind of masking that lupus anticoagulant. But thankfully, we did other assays and were able to detect that for her. And then if a disorder of fibrinogen is suspected, one of the main assays to start with is a thrombin time. So your thrombin time measures the time it takes for fibrinogen to be converted to kind of fibrin and form a nice clot. Thrombin time can be prolonged by heparin, kind of underlying afibrinogenemia, hypofibrinogenemia, or dysfibrinogenemia, and then can also be prolonged in the presence of fibrin degradation products such as, we see in DIC. Diagnosis of afibrinogenemia and hypofibrinogenemia are fairly simple from there. They're detected by either an undetectable in afibrinogenemia or decreased fibrinogen in hypofibrinogenemia. People with dysfibrinogenemia is kind of where it gets tricky to diagnose, as this is more of a qualitative defect. And so while we can see low fibrinogen levels, it's not always the case. Sometimes patients will have normal fibrin fibrinogen levels and still have dysfibrinogenemia. The diagnosis really relies on both a prolonged thrombin time and then also a discrepant clotable fibrinogen to fibrinogen antigen ratio of less than 0.8. For individuals where you might suspect dysfibrinogenemia, genetic testing is becoming more available and I think utilized to really kind of confirm diagnosis and also can be helpful for trying to predict phenotype just because the individuals with dysfibrinogenemia have a pretty wide spectrum of symptoms ranging from increased clotting to increased bleeding and anywhere in between. So sometimes the genetic testing can also be helpful there. All right, and then for acquired von Willebrand syndrome, which might be more likely for us to be seeing in some of our patients with pancytopenia, maybe more often than some of the congenital bleeding disorders. So it should certainly always be considered if you have a patient with excessive bleeding and they have an underlying autoimmune condition or myeloproliferative or lymphoproliferative disorder as well. There are kind of multiple proposed mechanisms for acquired von Willebrand syndrome based on the underlying disorder. In individuals with autoimmune conditions such as lupus, it's thought that autoantibodies that interfere with platelet or collagen binding domain can impact your von Willebrand factor function and then also lead to increased clearance of the von Willebrand factor protein. In myeloproliferative and malignant disorders, it's more of kind of a thought to be sequestration of your high molecular weight maltomers, which, if we all remember, are kind of our stickiest and are more effective. And these high molecular weight maltomers adsorb to tumor cells, or for patients with myeloproliferative disorders, they can adsorb to platelets and are kind of sequestered away from the endothelial surfaces. In individuals with cardiac defects, there is typically increased clearance of the high molecular weight maltomers as they're cleaved from the protein under shear stress. And then lastly, in hypothyroidism, it's thought that it's actually just a decreased production of von Willebrand factor proteins, kind of similar to someone with like a type 1 von Willebrand disease. Diagnosis of acquired von Willebrand syndrome can be tricky, as oftentimes the von Willebrand factor levels themselves are normal, since outside of underlying hypothyroidism, with acquired von Willebrand syndrome, typically production of the protein is normal. So multimer analysis is really imperative to help evaluate for specifically loss of high molecular weight multimers, which is commonly seen as they're cleared from circulation. And then additionally, looking at your von Willebrand factor activity to von Willebrand factor antigen ratio is helpful, as typically there's often pretty big discrepancy between the levels, even if they're both in the normal range, and sometimes they can even be elevated. But despite patients having kind of higher von Willebrand factor levels, we still see bleeding because they're missing kind of those high molecular weight multimers that are so effective. So moving to just chat a little bit about some of the more rare acquired factor deficiencies. These should be considered, just if you get a history that kind of supports a possible diagnosis and you've exhausted other options for your atypical bleeding. So for acquired factor V inhibitors, these can develop, as I mentioned earlier, following use of bovine thrombin, which previously was commonly used for hemostasis in cardiac surgery, sometimes in neurosurgery and otolaryngology procedures as well. I don't think it's being used as frequently now. I think I've only seen one case of this, and it was about 6 years ago. So I think a lot of the cardiac surgeons have moved away somewhat from using bovine thrombin. But the bovine thrombin essentially is contaminated with coagulation proteins, in particular factor V. And upon repeat exposure to bovine thrombin, inhibitors can be formed to the bovine, and then to bovine factor V, which then can kind of cross-react with our human factors as well. And antibodies typically will form about 7 to 10 days after exposure and then last for, a few weeks to months in circulation. Roughly 30% of patients will have bleeding manifestations, which can range from just some easy bruising to some patients will have GI hemorrhage and also intracranial hemorrhage as well. These are typically going to be treated with immune suppression, in particular steroids and IVIG and cyclophosphamide are typically used. And then occasionally in the setting of kind of life-threatening bleeding, plasmapheresis will also be used. For patients with acquired hemophilia, which typically is factor VIII, is acquired hemophilia A is the most common. It's exceedingly rare, but it can be seen in the setting of immune disorders, including lupus, rheumatoid arthritis, autoimmune thyroiditis, and antiphospholipid syndrome. And then the other kind of second most common setting for acquired hemophilia is pregnancy. And these are neutralizing autoantibodies that form against factor VIII most commonly. And we also use immunosuppression to kind of eradicate these inhibitors. And then we'll use bypassing agents to kind of treat the bleeding. And then the last kind of rare disorder to think about is lupus anticoagulant hypoprothrombopenia syndrome, which can contribute to excessive bleeding as well in individuals with pancytopenia, particularly in patients with lupus. So in LAHS, non-neutralizing antiprothrombin antibodies are formed, resulting in rapid clearance of your prothrombin. And these antibodies can be tested for and detected via ELISA assays. The diagnosis can be missed on just a routine mixing study. Since the antibodies are non-neutralizing, the PT will be very prolonged at baseline, but upon mixing actually will correct. And so your typical laboratory pattern that you'll see are PT and PTT will both be pretty prolonged. Prothrombin levels, if you measure them, will be quite low. And then you'll also be able to detect the presence of a lupus anticoagulant on screening. As I mentioned, LAHS is typically associated with newly diagnosed lupus, but has also been reported following adenovirus infections as well. And typical presentation is that patients will have kind of a sudden onset of bleeding, which can be anywhere from mild mucocutaneous bleeding to GI hemorrhage and hemarthrosis. And treatment for this typically also might involve plasmapheresis in individuals who are having life-threatening bleeding to try and remove those antibodies from circulation. Otherwise, if bleeding is more mild, then using FFP just as a source for prothrombin repletion can be helpful. And then for individuals who have kind of newly diagnosed lupus, early initiation of steroids and rituximab has been helpful at kind of clearing these antibodies as well. All right. And then switching gears a little bit into management of bleeding. For individuals with pancytopenia with epistaxis, regardless of the underlying cause, whether it's thrombocytopenia alone or thrombocytopenia plus a congenital or acquired bleeding disorder, I think the best way to manage it is to try and prevent it. So in addition to, platelet transfusions as needed based on whatever the platelet count is, other techniques to prevent epistaxis really should focus on decreasing irritation and increasing moisturization within the nasal passages. So cool mist humidification at night can be very beneficial, although I think again in our patients with pancytopenia, we have to be pretty thoughtful just with the risk of infection if people aren't properly cleaning and maintaining their humidifiers. Oftentimes they do stray away from this recommendation in patients who are neutropenic. A good alternative is just aggressive use of nasal moisturizers. So things like air gel, Vaseline, saline sprays, using those at least 4 times a day for patients to try and prevent nosebleeds. Also avoiding trauma, in particular for younger kids, trying to discourage them from picking their nose can be very beneficial. Smoke exposure can be extremely irritating to your fragile blood vessels in the nasal mucosa, so trying to avoid that. Also, cold air can be, definitely dries out the nasal mucosa. And so encouraging kids to wear like a scarf over their nose when they're outside in cold weather can also be helpful as well. Along the same lines, chlorinated pools can be really irritating. So if there's a kid who, has just had a bunch of nosebleeds, typically I will tell them, try to avoid going in the pool for at least a week afterwards. Let things kind of heal up and let's rehydrate your nose before reintroducing the swimming pool. Treating allergies and hypertension can also be helpful. One of the issues with a lot of the allergy medications is that they also can lead to drying out nasal mucosa as well. So you can kind of get caught in this vicious circle. And so for patients, if we are prescribing them medications to treat their allergies, really, really emphasize that they also need to be keeping up with all the nasal moisturizers at the same time as well. And then in general, just maintaining adequate hydration is important also to keep your nasal mucosa happy. When managing acute epistaxis, I think we all know the first line of treatment is direct pressure for at least 15 minutes. Sometimes over-the-counter products can be helpful for kids or adults that don't want to sit there and hold pressure for 15 minutes. So Nampons are really helpful. You can insert them into the nose and they, apply pressure, or externally if they don't like some kids complain that the Nampons aren't that comfortable. Using kind of external nasal clamps can be useful as well. Likewise, there's various gauze products that you can get over the counter out there that are coated in calcium alginate. That's really helpful with clotting. So things like bleed cease, nasal cease, wound seal are pretty effective at getting bleeds to stop rather quickly. Direct application of aminocaproic acid using either a Q-tip, or you can soak it in gauze in the solution and kind of insert it into the nose. That can be helpful for managing an acute bleed. Another thing that I found extremely helpful is tranexamic acid via an intranasal atomizer. Can really help with kids with recurrent nosebleeds as well. Once the bleed is kind of resolved, using estrogen creams such as Premarin can be really helpful just to help kind of build up and thicken the mucosa inside the nose to provide some more protection to some of those really shallow, superficial, fragile blood vessels in the nose. And then also for kids who are having kind of clustered epistaxis, multiple nosebleeds in a day or multiple in a week, sometimes just putting them on, a week of systemic antifibrinolytics can be helpful. And we'll oftentimes recommend, taking it for at least 48 hours after the last nosebleed has stopped, just to allow some time to help, decrease fibrinolysis, give that clot there some more time to hang out, and allow the irritated vessel underneath it to heal. Cauterization can also be used if patients are really not responding to any of the supportive care measures. And then for anyone who has an underlying congenital or acquired bleeding disorder, obviously also treating those more directly if the bleeding is pretty severe. So, for instance, with individuals with von Willebrand disease, if they're having a really severe nosebleed that's been refractory to other therapies, using things like von Willebrand factor concentrates or using intranasal DDAVP if there are no contraindications can be beneficial. For oral mucosal bleeding, again, prevention is imperative. We typically talk to all of our patients and encourage really good dental hygiene just to try and minimize the need for dental procedures, which obviously have increased risk of bleeding during and after the procedure. And then also just to prevent like gingivitis associated bleeding as well. For patients who have had oral mucosal bleeding, we typically encourage them to avoid straws since the kind of like sucking can lead to dislodging any clots that have formed and in their mouth. Kind of thinking along the same vein, avoiding hard foods for 24 hours after a bleed, and then avoiding vigorous swishing of like mouth rinses and things like that after a bleed, just again to try and prevent dislodging any clots that have formed. Once again, antifibrinolytics work great for oral mucosal bleeding. I typically will prefer to use oral solutions for oral bleeding just because you get some direct and systemic effect from them. One thing that is currently like all the rage amongst our bleeding disorder patients is these antifibrinolytic ice lollies. And so parents have been taking their antifibrinolytic solution and mixing it with like juice or like the flavored water packets and making like little ice cubes with sticks in them so that, and they just keep a tray in the freezer at all times. And if the kids have a bleed, they pop one out. And it's really great for kids who don't like to take medications or who don't really want you, holding pressure on something in their mouth. You give them this, they think they're getting a treat. And the ice also helps with, local vasoconstriction to aid to help decrease bleeding as well. So those have worked really well for our patients. For patients who are having heavy menstrual bleeding, which is also pretty common for patients with pancytopenia, hormonal regulation, so oral contraceptives can be very effective at decreasing flow. For individuals with concurrent anemia, one advantage of kind of hormonal regulation is that we can fully suppress menses, which is often desirable for patients who are pancytopenic and may be transfusion dependent, requiring both PRBCs and platelet transfusions. In addition to oral contraceptives, there's also, IUDs can be really beneficial for this patient population as well. There's obviously numerous oral contraceptives to choose from. One thing to consider is whether patients have any underlying thrombotic risk, and just when you're thinking about whether or not it's safe to use like a combined pill with estrogen, or if there are underlying thrombotic risks, probably steering away from the estrogen containing pills and using a progesterone only product. And then antifibrinolytics also can be used for heavy menstrual bleeding. They can be used safely concurrently with oral contraception if needed, and they do work pretty well at decreasing bleeding. However, unlike the oral contraceptives, we can't really fully suppress periods for patients. And so if they do have, like I mentioned, kind of baseline anemia that we're worried about sometimes, using the hormonal medications can be a little bit more beneficial. The other thing they don't help with are irregular cycles. And so if you have a patient who's having periods like every 2 weeks, usually I will try and steer them towards an oral contraceptive if they're willing. And you probably noticed that antifibrinolytics came up a lot on for all types of bleeding. And so might be wondering if it would be beneficial to use just antifibrinolytics prophylactically for patients with pancytopenia. And so the ATREAT study kind of sought to answer that question. ATREAT was conducted in patients with hematologic malignancies. And they kind of sought to address the question if prophylactic tranexamic acid specifically could minimize transfusion requirements in patients with thrombocytopenia secondary to treatment of their underlying hematologic malignancy. And this was a randomized double-blinded trial that enrolled 330 patients, and they were randomized to receive either tranexamic acid versus placebo every 8 hours, which would start when the platelet count dropped below 30 and continue until platelet recovery. And platelet transfusions were given throughout the study for platelets less than 10,000 pre-procedurally, and then at the discretion of the provider if patients were having bleeding. Endpoints of the study were kind of looking at the proportion of patients with WHO grade 2 or higher bleeding within 30 days of tranexamic acid initiation. They also looked at number of platelet transfusions, number of days alive without grade 2 or higher bleeding, and they also looked at thrombosis, development of VOD, and mortality. And what they found is that essentially there was no statistical difference between the tranexamic acid arm and the placebo arm in any of their endpoints. And so conclusion was kind of that prophylactic tranexamic acid, while safe in the setting of thrombocytopenia, was not necessarily beneficial at reducing bleeding or transfusion requirements in individuals with pancytopenia from hematologic malignancy. So I think if we extrapolate this to other populations, it seems reasonable for now to continue to use antifibrinolytics on an as-needed basis for bleeding. And I think that is it. Happy to take questions if there are any.
We do have a question in the chat.
Oh,
For VWF testing, what qualitative assays does your lab use? Are there certain ones which are less affected by inflammation, stress, etc., like GP dash, I don't, forgive me, 1X or collagen binding? And then the second question was, what is the dose of vitamin C you recommend in your hypermobility patients?
yeah, great questions. So our lab currently is still using the ristocetin cofactor assay for von Willebrand factor activity, which does have many pitfalls. In particular, there are a lot of individuals of African descent who have a specific polymorphism, which I'm going to forget right now. I think it's like I can't remember off the top of my head, but we have a lot of basically this polymorphism causes lower ristocetin cofactor activity levels, but is not associated with any clinical bleeding. And so there is a lot of kind of false positive testing essentially in that specific population. And so the newer guidelines for VWD diagnosis have recommended moving to more platelet-based assays for diagnosis, including like the GP1BM assay. Whether or not those are less affected by inflammation and stress, though, off the top of my head, I don't know if any specific studies have been done looking at that, but I don't believe that they are less impacted by inflammation and stress. But in general, they are more sensitive for diagnosis. And then vitamin C dosing, I can't remember that off the top of my head either. It's been quite a while actually since I've had a patient with hypermobility syndrome on vitamin C. So I'd have to look that up for you. Any other questions though?
This is really great. Thank you. I had not heard of the ice lollies, so I think I might
Yeah.
have to use that in some of my patients.
Yeah, I actually found out about them at one of our VWF Connect where it's meetings for the patients, and one of the patients brought them up, and yeah, they're great.
From what I understand, the liquid Amicar does not taste very good. So if that can make it
No.
palatable and the cold, I mean, together, it's just like the perfect
Yeah.
combination. Genius.
Yes. Yes. It's been life-changing for me. So I can only imagine for patients who are actually, or parents that are actually dealing with the bleeding.
Well, thank you very much for this. It was really great. And we appreciate your time and all of your expertise.
Yeah, thanks everyone. Have a great Thanksgiving.